Well, good morning. It's always good to come back to India, my second home. Before I go into my talk on urinary tract infections in children, concepts and studies, I just want to go off script for a minute to talk about, to continue what Warren and Nicole talked about. I mean, they really have emphasized to us the importance of prospective databases in looking at outcomes of our surgical procedures. But that concept is incredibly important for even our non-surgical problems that we deal with. During the symposium that we just had, the mini symposium last time, we heard a lot of people say, "in my practice." We hear that all the time when physicians talk about what they do in their practice, their background, their bias, their prejudices. And that really hurts our understanding of these conditions. What we're trying to do in Columbus is get rid of the concept "in my practice." What we're trying to come up with is a protocol-driven prospective management of all these children. What we want to do is come up with a system where every single physician asks every single child the exact same questions. And by recording those answers, that's really going to be the only way to come up with an understanding of how to take care of these kids. Physician A, the way he or she addresses dysfunctional voiding may be completely different than some other physician. But unless we have some uniform way of asking these questions and recording those answers, we'll never really understand what's going on. So we are trying to do the same thing that Warren and Nicole have done for hypospadias for urinary tract infections, but not on an individual physician point of view, but from an entire divisional point of view. And we're doing the exact same thing in our spina bifida clinic, in our colorectal pelvic reconstruction clinic. We're trying to expand this onto multiple different topics. But with that introduction, I'll begin. I'd like to introduce my talk with a case. I know we should not be anecdotal, but I thought it would be helpful to start with a case. This is a patient that was referred to me several years ago by a pediatric nephrologist. This child was having recurrent breakthrough infections on prophylactic antibiotics. The nephrologist saw the report from the radiologist who talked about high-grade reflux. She sent the patient to me to do surgery. Well, I looked at the films and I talked with the child. I talked with the family. This child had significant incontinence, had voiding dysfunction. You can see the stool that's all the way coming up the right side of her colon. You can see this abnormal bladder there. This is far from primary reflux. So what did I do for this child? Ditropan and a bowel clean out. And look what happened. In 1 year, the reflux has improved markedly. The bladder configuration has improved. The bowels are much better. This is in just 1 year. She's now 3 years out, has not had a single infection. Reflux is gone. She's perfectly fine. So I introduced this to talk about the following concept. True, but unrelated. Steve Koff, one of my mentors, and my senior partner used to use this terminology all the time. True, but unrelated. What does that mean in this specific child? True, this child has high-grade reflux. True, this child has had multiple breakthrough infections despite being on prophylactic antibiotics. Unrelated, the reflux has little to do with the infections in this particular child. Just because both coexist does not mean that they necessarily are related. Just because a child has an anatomical abnormality does not mean that the child needs anatomic management. Very, very simple, important point. I want to talk about one more case. This is a newborn with prenatally detected hydronephrosis. One of my former partners saw this child a few years ago. Very, very frightening looking kidneys. Echogenic kidneys on either side, significant hydronephrosis, massive reflux, possibly even some degree of an ectopic ureter. This family was told there's a very high likelihood your child is going to need to have surgery at some point, but because your child is so young, we'll watch your child for a while until he is big enough to have surgery. Well, what happened? I took over the care of this child and observed her. 3 years later, look at this. Hydronephrosis is essentially gone. The reflux is gone. The child's off antibiotics. No urinary tract infections ever. The point being that on an individual basis, you cannot make a decision about whether that child needs surgery or not at a single point in time. Why do we deal with reflux? Why do we worry about urinary tract infections? You know, one thing we always worry about is whether the child is going to end up in renal failure. We see all these kids with reflux. Parents are frantic that their child's going to lose their kidneys, end up on dialysis, and need renal replacement therapy. Well, what has happened? What has happened? You know, has the modern management of reflux resulted in a reduction in the incidence of end-stage renal disease? This came from Australia about a little over a decade ago. They looked at the new patients they saw with end-stage renal disease at different ages over the course of 30 years. New patients 5 to 14 years of age, the reflux-related straight line, no improvement. 15 to 24 years of age, again, over a 30-year time period, there was no change in the rate of end-stage renal disease. Looking at older patients, again, nothing. Older patients, there has been absolutely no change in the rate of renal failures. What does this tell us? Modern reflux management, if we were doing great at preventing renal failure, that number should be going down. But it hasn't. It hasn't. Because what that tells us is that all of our management for reflux has little to do on a global basis in reducing the risk of renal failure. Renal failure related to reflux is due to bad embryology, and we can't affect that at all. The one thing we don't know is if reflux management will reduce the risk of hypertension. This might be a real issue. This might be real. Reflux-related hypertension in children is exquisitely rare. It's very, very uncommon. What we don't know is if these kids are going to grow up into middle-aged adults who have an increased risk of hypertension and all subsequent complications thereof. So for me, if I am treating reflux, it's to see if we're preventing hypertension. We have no idea if that's really going to happen or not. Do prophylactic antibiotics matter? This is a big question that everyone is asking these days, and it all started when Guerin published this really crappy paper back in 2006. And using children, you don't really worry about grades 1 to 3. They really showed there was no difference between groups with respect to the rate of infections or scar development. This paper out of Italy had a wider range of patients they were looking at, and they also found no difference between groups with the respect of rate of infections or scar development. So early on, people started saying that antibiotics don't matter. Subsequent studies have been done, however, which show that there may be a role in specific age groups. The Swedish reflux study was a randomized trial of children 1 to 2 years of age with higher grades of reflux, looking at prophylaxis, endoscopic treatment with surveillance. And they found that there was a difference. There was a difference, and that there was a higher rate of breakthrough febrile infection in girls specifically who were just observed as opposed to those who were on prophylactic antibiotics. So this study did show that there was an advantage to prophylactic antibiotics in younger kids with higher grades of reflux. The RIVUR study also showed similar findings with regard to a benefit on having children on prophylactic antibiotics, that there was a reduction in the risk of infections, but not scarring if you're on prophylactic antibiotics. But my point in talking about these studies is I think that we are making a bit of a mistake in keying in on those who had urinary tract infections. We always focus on those who've had UTIs, but we should also think about those who did not. Why did 233 of the patients with reflux who were on placebo not develop an infection. What was special about those kids that led them to be infection-free compared to those 24% who did have an infection? We need to answer these questions rather than just knee-jerking giving all kids with reflux antibiotics. We need to understand why certain kids get infections and certain kids don't. Also, conceptually, there was about 13% reduction in the risk of having infections if you're on antibiotics. Should we place all children on prophylactic antibiotics just to prevent the 13% from having infections? I don't know what the answer to that is, but I think something that we really need to think about to understand what we're doing. I think what all this means is, at least for me, I'm speaking for myself, I know very little about urinary tract infections. I don't understand much about renal injury right now, and I still don't understand the relevance of reflux with all these conditions, and we really need to understand better what all this means. Several guidelines and several papers have come out lately about what to do with these kids. The American Academy of Pediatrics came up with these clinical guidelines a couple years ago about the management of initial infections in children. It's caused a lot of controversy. I'm not going to talk about their action statements 1 to 4 because this is really designed for primary care providers. This emphasizes the importance of proper specimen collection, looking for pyuria, avoidance of bag specimens, how to truly diagnose urinary tract infections. I don't think there's too much of a controversy in this room. But it really then becomes contentious, though, when you look at their recommendations for what type of imaging studies should be done. The recommendation, or the guideline, is that children with urinary tract infections in this age group should only undergo an ultrasound, no VCUG. It's been axiomatic amongst pediatric urologists that if a child has a febrile urinary tract infection, they should have both an ultrasound and a VCUG to look for reflux. But the latest guidelines would suggest that you only do a renal ultrasound but no VCUG, and that the VCUG should be considered if there is an abnormality on the ultrasound, such as hydronephrosis or other findings, or if the child were to have recurrent urinary tract infections. So this is very, very contentious because we urologists are so fixated on the concept that reflux is the primary issue, or a primary issue, in the incidence of urinary tract infections in children. As part of this guideline, they did collate all the articles that they had, and they came up with a hypothetical cohort of 100 infants and what would happen if you did all the studies. We all know that if you have a febrile urinary tract infection, 2/3 of them do not have reflux, or anatomically normal, and so they really don't need to have VCUG because they don't have reflux. And then the majority of reflux that's detected is of lower grade. So after a first single febrile infection, the chances of having a high-grade reflux is really relatively low. So that is the reason behind the suggestion of not doing a VCUG up front. The AUA also came up with some guidelines for the management of reflux several years ago. And I find it interesting that guidelines are controversial. They try to make them so all-inclusive as to keep everybody happy. But the one thing that they said is a standard, not a recommendation, not an option, but a standard, is that all kids with reflux have to have an evaluation of bladder and bowel dysfunction. And I'm not sure we do that. I'm not sure that we really spend the time or ask the questions that need to be asked to understand if a child is having these issues. So often some docs will simply say, does your child have constipation? And the parents will say no, because they look at it as a sign of personal failure as parents if their kid's constipated. But you really need to have very, very specific questions to try to understand if the child has underlying voiding dysfunction. The AUA also put out these guidelines that continuous antibiotic prophylaxis is recommended for children less than 1 year of age who have a febrile urinary tract infection. Forgive me if I put a personal opinion in here. I know this is not evidence-based, but my personal opinion is that I don't. I think that there's enough data out there which would suggest that the lower grades of reflux do quite well without any antibiotics. And so I personally would only use continuous prophylaxis in children with higher grades of reflux. Or perhaps equally important is if the family does not have good primary care. I think that this latter aspect is probably one of the most important aspects in the management of kids with reflux. We're not the ones who protect kidneys. It's the pediatricians. The pediatricians are the ones who have to do early diagnosis of urinary tract infections and early treatment. They're the ones who ultimately protect kidneys, not we surgeons. Another recommendation that they gave is in the absence of a history of urinary tract infections, continuous prophylaxis is recommended for kids less than the age of 1 who have reflux identified through screening. My personal opinion is no screening. I know that several years ago, Tom Noe, or Butch Noe, came up to these papers showing that a third of kids' siblings will also have reflux, and many people began to screen all family members to see if they had reflux. I think that the pendulum has swung away, and I think that most pediatric urologists these days have gone away from that, and I don't think that many people have continued with screening at all of siblings for reflux. We talked earlier about the circumcision issue. I think that circumcision is such a personal, familial issue that I personally never suggest circumcising a child just because they need to try to prevent infections unless the family really, really wants it. So how do I treat reflux? Prophylactic antibiotics when the child has the greatest risk of infections and scarring. And typically, once they're a little bit older, out of diapers, dysfunctional bladder and bowel habits are stopped, then stop all antibiotics and observe the kids. This is the standard management for the majority of these kids. And surgery is reserved for failure of medical management if they have breakthrough infections or evidence of renal injury, progressive renal injury, which is really relatively uncommon, just doesn't happen often, and if they have recurrent infections after antibiotics have been stopped. In preparation for this, I tried to get some data from our hospital. The numbers I'm going to give you are from our billing department, so it's not pure scientific data. But in calendar year 2013, we saw 409 new patients with urinary tract infections in our division, 606 established patients for follow-up, or over 1,000 children with urinary tract infections. During that same year, we had 169 new patients that we saw with reflux, and 266 patients we were following. So we had over 400 patients with reflux that we urologists saw in calendar year 2013. So I think it's a fair number of kids that we saw. I then looked at how many of these kids ended up having a surgical intervention. 38. 38 kids in our institution had a ureteral reimplantation. We had 10 kids who had deflux injections, so just under 50 kids. Now, I'm not saying that this is right for everybody, but with the way we manage reflux, having specific strict criteria for surgical intervention, the overwhelming number of children with reflux never come to surgery. Now, what we need to do now is prospectively prove that these kids are having equal outcomes. That's what we need to do. But in our institution, most kids with reflux never go to surgery, and those that do have a problem. They keep having infections. There's a specific problem in a specific child. So, as pediatric urologists and surgeons, we have always focused on anatomy and function. But the future needs to focus on what causes urinary tract infection, host factors and bacterial factors, and non-pharmacological methods of treatment. We all know that we abuse antibiotics, and we have to come up with better ways of preventing infections. This slide was put together by one of my former fellows, Doug Storm, to really understand why urinary tract infections lead to scarring. it is really an interplay of several factors, factors that we don't quite understand yet. It's an interplay between the bacterial virulence traits, host innate immunity, and urinary tract function. And there's some relationship between these three factors which will then lead to the potential for renal damage. This is why 76% of kids who have reflux will not have any infections, even though they're not on prophylactic antibiotics, because of these factors here. I put this picture up for the following reason. Bernie Churchill is a pediatric urologist at UCA Children's, and he has come up with some remarkable new technology where he can take a urine sample and, looking at RNA analysis of the bacteria, within 1 hour tell you what the antibiotic is, what the bacteria is, and what antibiotic to use within 1 hour using modern science technology. This is incredible, incredible stuff. And as I think about what we can now do with bacterial identification, I can't help but think that as time goes by, as our basic scientists are better able to look at urinary markers of renal function and bladder function, that at some point in the future we'll be able to determine up front, based on urine samples, blood samples, some other samples, what child needs treatment and which child doesn't need treatment. We're a ways from that, but we're going to look back on how we do things right now and think that this is very, very primitive. I think that as we look forward to the future, we really have to try to do a better job at looking at probiotics and non-pharmacological ways of dealing with urinary tract infections. We are about to start a study in Columbus with this probiotic that is a derivative from a fecal sample from 1917 from a soldier who survived World War II in Germany, World War I in Germany. And this particular bacteria appears to have bactericidal effects on uropathogens in vitro. I think that the future, one of the futures of urinary tract management is going to be in coming up with these type of bacterial species that can compete with uropathogens and help prevent infections from occurring in the future. We really have to start thinking outside the box. I'm going to conclude with a couple paragraphs here. A couple weeks ago, I was throwing away some old textbooks from my office, and I came across this book, Pathogenesis and Treatment of Urinary Tract Infections. This book was written in 1980 by Thomas Stamey, who is one of the fathers of urinary tract infections. So please bear with me for a minute. Some of the younger individuals in the room may not know that in the early 60s, a lot of people thought that bladder outlet obstruction was the cause of urinary tract infections. And a lot of children underwent bladder outlet surgery trying to prevent urinary tract infections. It was later proven to be unnecessary. But what Tom Stamey wrote was that it is not important that so many urologic authorities who enthusiastically wrote and endorsed vesical neck obstruction 10 years ago were wrong, because one half of what all of us believe today to be true will most certainly be shown one day to be incorrect. And humble man that he was, he said, including the material in this book that he wrote. You know, but surely from the point of history alone, should not many of those who so strongly believe today that ureteral reflux or distal urethral stenosis is the basis for childhood urinary infections recall the recent enthusiasm for correcting vesical neck obstruction? Indeed, it is of interest that several authorities and staunch advocates of ureteral reflux as the primary cause of urinary infections today believe with equal conviction less than a decade ago that the vesical neck was the major cause. I put this up there because we talked about this in the last session also. You know, a lot of what we believe to be true will be proven to be not true. But I don't look at that as being a negative. That's a positive, because that just shows an advancement in our overall state of knowledge and understanding. So with that, thank you for listening.
Thank you, sir. Many interesting concepts. A couple of quick questions and comments.
Thank you, Rama. Nice talk. I have one basic question. Does pyelonephritis lead to a scar? And if it is yes, and we do not know which one is going to become a scar, is it worthwhile reducing the incidence of pyelonephritis? by a method like medicines or surgery?
Yes, I would say absolutely that pyelonephritis can lead to a scar. But I'm sure that Nicole is probably going to show about the DMSA studies, which will maybe better answer that question. But the important thing to think about is this. We are so fixated on reflux. And yes, reflux can be a bad problem. But pyelonephritis, the majority of kids with pyelonephritis do not have reflux. They don't have reflux. And the majority of kids with pyelonephritis and reflux, if they're having infections, it's not the reflux, but the bladder dysfunction. That's the point.
So another question here.
The current American Urology Society meet done in May, they have brought out an article saying guidelines given earlier have proved to be wrong, showing thereby that, see, we have gone through the cycle that earlier we were aggressively using antibiotics as a continuous prophylaxis, and subsequently there is a period where the continuous prophylaxis has been stopped for the minor grades of reflux and used for major grades of reflux. And presently, in the last May, guidelines have given rise to higher rates of infection in those children in whom the continuous antibiotic prophylaxis has not been given. This is in the May.
Okay.
So, the article which I sent to Dr.
Yes.
Kanishka Das 2 days ago.
If I could just make a very brief comment regarding the business guidelines, because I was on that second guidelines panel. And so I was right in the meeting when we were having all these discussions. And the fact of the matter was that we didn't start that guideline to look at this question. While we were working on the guideline, which we saw as a way to fill in gaps from the first reflux guideline panel, looking at things like prenatal hydronephrosis and other factors that had not been addressed before, these articles that Rama mentioned started coming out, and we realized what we were about to put out was going to be considered totally irrelevant if we didn't try to address this issue of antibiotics and all that. So this recommendation, for example, to give antibiotics to kids less than a year of age, I remember who pushed that because that was me, and I don't do it either. But at the time, we were trying to look for some kind of recommendation that would balance reducing universal antibiotic prophylaxis and trying to focus it on those in whom it might benefit most. And we thought that so many infants get admitted to the hospital with their pyelo, whereas older kids are treated as outpatients frequently, that maybe that was a reason. So my point in saying that is to say that when we're looking at evidence-based medicine, remember that guidelines generally are level 5 evidence. You put together a bunch of people in the room, they weigh this and try to come up with some recommendations, and oftentimes there's just not enough evidence available to answer the questions we want answered, and yet you're pushed to answer it, so you give an opinion. So when you look at those, you have to be careful. Where did the evidence come from to support it? I agree with you completely in pointing out the weaknesses of that.
We have a last comment from Dr. Bajpayee.
Thank you, Rama. As usual, out of the box thinking that you do. Your question was very pertinent. The first 2 years of data coming out from RIVUR suggests that the infections do get a little bit more controlled with antibiotics than placebo. And you said, what about those on placebo who never had infection? The question is about those 15% who have infection, how to identify them. The problem is the point, when a point comes when we can identify those 15%, which are the volcano, where the problem is all about, it is only then we can say, well, we cannot give a blanket statement of giving prophylaxis. That's one. Secondly, in the same article, there was a quoted figure of about 17% of normal ultrasounds included patients who returned with VUR and UTIs. 1/3 of these were grade 3 to 5 and with cortical defects. So ultrasound as a screening has its own fallacies, which is well known, but at the same time. Now third is when to ask for a VCUG. So everybody, even AU has it mentioned in its UTI component of the guidelines that if there is a UTI, call for a, because they say that anomalies have a higher incidence of pushing to pyelonephritis. So I think lot of filtered away now, and we are looking at data which are probably come out of a huge sort of journey, and things are getting clearer. I'm not talking about sterile reflux for a moment. We are talking about, and only when we are not looking at things which is damaged by sterile reflux, we are looking at those things we are practicing and saying, well, as Wheeler said, that even if we treat UTI by antibiotics or surgery, it doesn't really matter because all are equally damaging. So if the damage is the window through which we are seeing and everything is get damaged, then obviously we are not going to get an answer. We have to look at those who can be protected by surgical intervention or for that matter any intervention.
Yeah, I would say, I mean, again, that there are some kids for whom reflux is a bad problem, but for the overwhelming majority, it's not. And so I think that if we are very completely objective and just try to give these kids a observational management, I think that the majority of kids just outgrow their reflux without having any damage at all.